Yeah.
Good morning, everyone. My name is Faisal Widrago. I'm a first-year cardiology fellow here at VCU. Thank you for attending our grand rounds today, which is also part of our Crutchfield lectureship. I hope the folks online can hear us well without any problem. George and Frances Broaddus Crutchfield Endowed Lectureship was established by Frances in 2013 in memory of her husband, George. The fund supports a lecture series on heart failure and cardiac care. George Crutchfield was a respected figure in the field of communications and journalism. He served as the director of VCU's School of Mass Communication from 1970 to 1989 and played a pivotal role in its growth from a print-oriented journalism department to a comprehensive school encompassing broadcasting, public relations, and advertising. Even after stepping down as director, he continued to contribute as a professor until his retirement in 1999. Crutchfield was recognized for his achievements and received several prestigious awards, including the Virginia Press Association Lifetime Achievement Award in 2009. George unfortunately passed away in March 2011 at the age of 77. George had a strong interest in cardiovascular disease and the work of Dr. George Vetrovec and Dr. Hess. His desire to further education in heart disease continues through this fund. We thank Frances and George's family for providing this opportunity to welcome our 2025 Broaddus Crutchfield Lecture speaker, Dr. Mark Drazner. Dr. Drazner is currently the Vice Chair of Clinical Affairs and holds the James M. Wooten Chair in Cardiology at the University of Texas Southwestern Medical Center in Dallas, Texas, where he previously served as a clinical chief of cardiology from 2016 to 2025. Dr. Drazner is a widely recognized national leader in the care of patients with heart failure. He served as president of the HFSA from 2021 to 2022. He has published numerous academic articles in top medical journals, served on writing committees for the ACC HFSA guidelines for the management of heart failure, and was chair of the recent ACC expert consensus decision pathway on the diagnosis and management of myocarditis. His excellence as a teacher has been previously recognized through multiple awards. In 2018, he received the Lennox Master Clinician Award from the AHA, and in 2020, amid the COVID-19 pandemic, he received the Patricia and William Watson Award for Excellence in Clinical Medicine, the highest honor of clinical care at the UT Southwestern Medical Center. We are grateful for Dr. Drazner's expertise on the topic and look forward to learning from him. Few housekeeping before turning it to our speaker. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. And the folks in the room, you can always raise your hand and we can go right from there. We are pleased to offer both CME and MOOC credit for our Grand Rounds Conference series. To claim credit for today's session, text the code shown at the beginning and end of this presentation to 804-625-40241. For questions on or to log on to your Cloud CME account, visit vcu.cloud-cme.com. I'll contact Shannon Winston. I'll now turn it over to Dr. Drazner.
Thank you, Faisal, and for the kind introduction. And it's a real pleasure to serve as the Crutchfield lecturer. You look at the list of names who are preceding me in this opportunity, and it's humbling. It's also great seeing some old friends from UT Southwestern, Dr. Hunley, Dr. Rao. We go a long time way back, and so it's great seeing you as well. So what I thought I would do today is talk about key questions in evaluation of new-onset heart failure. My disclosure is that I really enjoy taking care of this patient population, patients with new-onset heart failure. And the focus of the talk will be this leading edge commentary. It was written by our two heart failure fellows, Michelle Dimser and Cliff Pruitt. Really, Dr. Dimser did the lion's share. And Jack heart failure. I got a email from Harlan Krumholtz saying that he really liked it, thought it'd be very helpful, and he's going to reprint it in Jack to feature it. So I thought it'd be a good topic for your cardiology grand rounds as well. And this is what we'll talk about. It's really focused on 5 questions. Should an ischemic evaluation for all patients with new-onset heart failure be done? When should a CMR be obtained in new-onset dilated cardiomyopathy? When to do an endomyocardial biopsy? What's the role of genetic testing? And then how long to wait before you implant an ICD in such patients? And so let's start with the ischemic evaluation. Here's a case, a 56-year-old man. He presented with new-onset heart failure in March of 2023, and EF was 20 to 30%, and he was readmitted 3 months later to Parkland Hospital, our urban public hospital, main teaching hospital, off his medications for a week with decompensated heart failure. I was rounding on the heart failure consult service and met him. He was positive for cocaine, had a 40-pack year history of tobacco, negative troponins. His ECG just showed LVH with strain. And when you look back, there really had been no formal rule out of ischemic cardiomyopathy. And the question was, should there have been some evaluation of ischemic cardiomyopathy? Well, when you think about patients who present with new-onset heart failure, there's a differential diagnosis that is familiar to everyone in the room. And of course, coronary disease is the most common. And so if you're a betting person, you're going to want to see, does the patient have coronary disease? It's the most likely cause. And so, of course, you should do an ischemic evaluation for all adults who have it. You're going to do your clinical evaluation. You're going to do a history and physical. You're going to ask, do they have angina? Do they have prior MI or PCI CABG? Prior evidence of stroke or carotid disease to increase the risk of coronary disease? Do they have claudication? You're going to look at the ECG and see if there's evidence of myocardial infarction, and then see if there's evidence of a troponin leak that suggests an acute coronary syndrome. But really the question is, if that initial clinical evaluation does not suggest coronary disease, should you still assess them for ischemic cardiomyopathy? And if you go and look at the guidelines, where we said it was a class 2A recommendation, patients with heart failure and evaluation for possible ischemic heart disease can be useful to identify the cause and management. Not a strong evidence base. It was a non-randomized recommendation. So what are the arguments for doing an ischemic evaluation? Well, as I said, coronary disease is the most common cause. If you're a betting person, you're gonna look for it. There's prognostic value. If the patient has ischemic cardiomyopathy, they're going to do worse than a non-ischemic. And of course, we have feasible therapeutic options, whether it's PCI or CABG. And we know that CABG extends survival. If you look at the Stitches trial in 2016, you can see that the patients assigned to CABG had about a 16% risk of overall all-cause mortality after about a decade of follow-up. So these are the arguments for why you should do the ischemic evaluation. On the other side of the equation, though, there are no randomized data looking in patients with new-onset heart failure showing that if you do routine assessment of coronary disease, that you're going to improve survival. And then if you look at the evidence base for revascularization in ischemic cardiomyopathy, there are limitations. CABG, there's early hazard, the benefits emerge after only several years, and really the benefit was constrained to patients who were younger. We now know viability, at least as assessed in Stitch, did not predict the benefit from CABG. And then the more recent, the REVIVE trial looking at PCI in patients with ischemic cardiomyopathy, it did not reduce the risk of death or risk of aborted sudden death. You can see on the right-hand side, death or heart failure hospitalization, no difference. So there's definitely weaknesses or limitations in the evidence base. And if there's no benefit of revascularizing, why look for the coronary disease? Well, could we screen for it? You could do stress testing. You can look anatomically, whether you look just at coronary calcium scoring or you look at coronary CTAs, cardiac MRI, or invasive angiography. And so I like this concept as you look at this about gatekeepers, using your non-invasive tests. The top article there looking at coronary calcium scoring or CTA, the bottom looking at CMR as a gatekeeper. So what are the evidence for that? This is a validation study, a systematic review, and they pooled the data, and they basically had 240 patients who had an Agassiz score of 0, so no coronary calcium. And of those 240, only 4 had an ischemic cardiomyopathy. On the right-hand side, you can see the C statistic was 0.94 to rule out an ischemic cardiomyopathy. So it's not massive evidence, but reasonable data suggesting that if your CAC score is 0, that's a pretty good screen for ruling out an ischemic cardiomyopathy. Of course, CCTA is, more detailed, granular data. And in fact, when you look at this is a meta-analysis of 5 studies. It has excellent diagnostic accuracy. You can see the pooled sensitivities and specificities, likelihood ratios are all excellent. This is on a patient-based analysis. So certainly coronary CTA is another very reasonable modality to screen for this. And then what about cardiac MRI? Well, if you look, these are two now somewhat dated studies, but still showing, if you look at here, the looking at CMR with gadolinium, the diagnostic accuracy was 97%. And if you look on the right-hand side, which is this is a retrospective chart review, it turned out that of patients who had late gadolinium, either absent or non-ischemic, that only 4 out of 36 were patients who had ischemic cardiomyopathy. So again, a very good rule-out test. So how do we put all this together? This is a flow chart that Dr. Dimser put in the leading edge commentary, and this is what we're suggesting, is that if you first estimate the probability of an ischemic cardiomyopathy through your initial clinical evaluation, your history and physical, your EKG and echo. If you do that and it seems like it's a low probability, then we recommend look to see many patients have incidental CTs of the chest. And you look at those and see, is there CAC on that? If there's no CAC on that, then it's reasonable, we thought, to do a cardiac CT, dedicated CT, to see if you have CAC or not, again, using CAC equals 0 to rule out the ischemic cardiomyopathy. If the prior chest CT shows incidental coronary calcium, or you have a CAC score greater than 0, or you think the patient's high risk, or not low risk, I should say, then you move to choosing an additional diagnostic test. And there we're advising either using a gatekeeper as the cardiac MR, the CMR, or the coronary CTA, or going right to invasive angiography. When would you go right to invasive angiography? Again, there's no hard data for this, but certainly if you think you need to do a right heart cath, if you think you need to do an endomyocardial biopsy, if you know the patient already has coronary disease, those would all be very reasonable people, I think, to go right to invasive angiography. And we thought that PET or SPECT, due to limitations either in the diagnostic utility or the expense of PET, would be second-tier testing in this algorithm. So that's what we're proposing as you see these patients with ischemic cardiomyopathy or new-onset cardiomyopathy, how to work through this rule-out technique. Well, what's the current data? If you look, for example, these are data from Denmark, where they have a national registry. It's 61,000 patients who had a new onset cardiomyopathy. And what you can see is looking at the ischemic evaluation, any type of ischemic evaluation was less than 30%. So at least across in Europe, it was not being done commonly, the screening. What about in the United States? This is from the Optum database. This is from 2004 to 2019, over 500,000. And here they've overlaid when Stitch, and then Stitches got published. Stitches is the extended trial that I showed earlier showing the benefit of revascularization. And yet here you can see that still in the United States, somewhere between 30 to 40% of our patients with new onset cardiomyopathy have any type of ischemic evaluation. This is 90 days before or after stress test, CMR, CCTA, or an invasive angiography. So the bottom line is it's not being done very commonly. And even more concerning is when you look at, now these are individual clinicians in the database, and look at this incredible variability where in the United States, some of us, it's under 20%, and others of us are doing it at 80%. When you see variability, you know that there's a problem and that there's a lack of evidence. We're all interpreting it what to do. We're all trying to do the right thing. It's just that there's not a robust evidence base to really guide us on this. So what I would say is that, yes, in all patients, you want to do a clinical evaluation, your history and physical, EKG, troponin, then assess the pretest probability. That'll influence your choice of your next diagnostic test. If it's low prob and there's nothing on chest CT, incidental chest CT, I think it's very reasonable to do CAC equals 0 as a rule-out strategy. But for others, either if they're moderate or high risk or they have any evidence of CAC, then take them to either a gatekeeper test, CMR, or coronary CTA, or invasive angiography. The current state, the bottom line is there's not high utilization despite guideline recommendations. And there's much variability in how we're practicing, suggesting we need more high quality data. Well, let's focus in a little bit on this CMR. I know certainly here with Dr. Hundley, we have the expertise in this room that you're all well versed in this. If you think about the etiology of patients who have new onset heart failure in the setting of a low ejection fraction, many of the causes that are highlighted here in orange can be identified by that initial history and physical laboratory test and routine echo. However, there are two, myocarditis and infiltrative processes, amyloid and sarcoid, that are challenging to identify on that initial screen. And I have to be honest with you, as I see these patients, these are the two that keep me up at night. How do I know that I'm not missing someone with myocarditis? How do I know I'm not missing someone with a disease, that there's disease-specific therapies like amyloid or sarcoid? And if I don't make the diagnosis, I can fundamentally, not give my patient the best care. Well, fortunately, CMR has reasonable utility in identifying these etiologies. And so it makes sense to apply CMR to patients with new onset heart failure. Going back to the guidelines, what we gave it, again, 2A, similar to the invasive angiography, you can see the level of evidence being non-randomized, is that CMR can be useful for diagnosis or management. This is a registry data, again, from Europe. This is just looking at the impact of cardiac MRI on patients who have new onset heart failure. And you can see it affected care about 62% of the time. So at least those data suggest there's utility in doing it. There is one randomized trial in this called the Outsmart HF that was published in Circulation. These are all individuals who had non-ischemic heart failure. And then there were 500 or so subjects. They got randomized to either echo plus routine CMR or echo and selective CMR. So they did the echo. If the investigator thought there was a specific reason to do the CMR, then they would do it. And then the primary outcome, they were followed for 12 months. The primary outcome was at 3 months to see what the heart failure etiology classification was. And it turned out, this is on the table 2, looking at the primary outcome, the specific heart failure cause, there in fact was no significant difference. It actually was higher in the individuals who got the selective CMR, and also there was no difference in 1-year survival. So it was a negative trial showing that a routine CMR added benefit over a strategy of selective use of cardiac MRI. On the other hand, I would say these are all patients who were known to have a non-ischemic cardiomyopathy. Ischemic cardiomyopathy had already been ruled out. And so in real life, though, when you're seeing a patient who's presenting, it has the added benefit of ruling out the ischemic cardiomyopathy, which is not captured in this trial. So, and then I also think as part of this equation, as you're thinking about should you do CMRs in these patients, is that there's other information that you're getting. And certainly if you look at, for example, the prognosis of late gadolinium versus just the ejection fraction, this was published last year in JAMA. And what you're looking here is at the late gadolinium and the ejection fraction. And here, if you look at mortality, for example, you can see that there was a significant increased risk of mortality. Here's 1, so it is a significant increased hazard of mortality with late gadolinium, but there was no significant increase in mortality with ejection fraction, suggesting that late gadolinium would be a better tool than ejection fraction, both for mortality and for cardiovascular mortality. There's a lot of questioning now about, ICD implantation, whether we should really be using gadolinium rather than ejection fraction to decide who to implant it. This is a really interesting study. I think that's worth reading, looking at the potential additive information you get from CMR compared to just anatomic coronary disease assessment. It's an observational registry, about 2,500 individuals. These individuals all had a low ejection fraction and known coronary disease. So you would say that all these individuals, these 25 people, had an ischemic cardiomyopathy. They all had angiography and cardiac MRI done. They then used an algorithm to define the etiology of the cardiomyopathy. So they looked at late gadolinium, they looked at the morphology of the left ventricle. Was the left ventricular dysfunction disproportionate to the extent of the coronary disease? So you have a right coronary 80%, but you have an EF of 20%, for example. Was it unrevascularized coronary disease? Did they have evidence of myocardial infarction? And they used all that information to come up to what they thought was the true etiology of the cardiomyopathy. And it turned out that of these 2,500 individuals, 1 or 6 of them, again, all of these would have been said to have an ischemic cardiomyopathy had you not done the cardiac MRI, but 1 in 6 of them turned out the final decision was that they had either a non-ischemic cardiomyopathy with superimposed coronary disease, or they had a dual non-ischemic ischemic cardiomyopathy. Now, this is very, this has profound implications, because if you had taken all these individuals and you said they all had ischemic cardiomyopathy and you send them to bypass, well, 1 or 6 of them who really had either a non-ischemic cardiomyopathy, an incidental coronary disease, or had a mixed picture may not benefit from revascularization. And maybe what you need to do is, before you decide or randomize people, maybe you should do the cardiac MRI and get rid of all those people who have a non-ischemic component, those 1 and 6, and only send the 5 and 6 to revascularization, and then see if there's benefit in revascularization. So I think it's a registry, it's not randomized, but I think there's pretty profound implications even for this whole question about, is there benefit or CABG or PCI in patients who have what we think is ischemic cardiomyopathy, recognizing that 15% of them really have a non-ischemic component to it. So what do the ESC guidelines say about this? They actually give this came out in 2023. Remember, our guidelines came out in 2022. They're given a class 1 recommendation for patients with contrast-enhanced CMRs recommended in patients with cardiomyopathy at the initial evaluation. That is not clearly the standard of care, what we're doing, but that's their class 1 recommendation. And then they go on to say that you even should do a follow-up cardiac MRI every 2 to 5 years, give it a class 2A recommendation. I see Dr. Hunley smiling, because there's going to be a lot more cardiac MRIs being done if these guidelines are followed. But I actually align with the Europeans on this. I think we should be doing cardiac MRIs on our patients. So should we be obtained? Well, certainly history, physical, basic labs, echo allow identification of many etiologies. But for those 2 that keep me up at night, that myocarditis, the infiltrative diseases, cardiac MRI is the way to go. And there's also this added benefit. You could identify ischemic cardiomyopathy, as discussed in the first question, and then also the risk stratification question for ICD implantation, as well as the overall prognosis. And again, it's now a class 1 European guideline recommendation to do that in all patients with non-ischemic cardiomyopathy. Well, what about endomyocardial biopsy? This is always the question that when I get called from referring physicians when they have sick patients with new-onset heart failure, should we do an endomyocardial biopsy or not? Well, here's a second case. This is a middle-aged woman who was previously healthy. She had a little dyspnea for a few months, but it got worse. And then she came into our center, had an EF of 23%. She had a markedly elevated high sensitivity troponin. For EKG and telemetry, she had high-grade AV block. We had to put a temporary pacer in. She started having salvos of non-sustained VT. We took her to left heart catheterization, no coronary disease, and we did an endomyocardial biopsy. And what you're seeing here are the giant cells. And so what she had was giant cell myocarditis. And this is the diagnosis you don't want to miss, because you have to treat it differently. You treat it with calcineurin inhibitors. And if you don't treat it with calcineurin inhibitors or high-level immunosuppression, it's not going to go well. So this is the things that keep me up at night. This is the one that really keeps me up. How do I know, how am I sure that my patient doesn't have giant cell myocarditis? Because you definitely don't want to miss that diagnosis. So what are the guidelines? This is the 2022 guidelines. Well, it should not be done routinely, because there's a risk of complications. And for most people, you don't need to do an endomyocardial biopsy. For most people, you do not need to do an endomyocardial biopsy. The question is, well, then who do you need to do it in? And what we said is that when specific diagnoses, kind of a generic statement, when specific diagnoses are suspected, that would influence therapy. But to give you a little more granular detail on that, if you think the patient has an infiltrative cardiomyopathy, amyloid or sarcoid, in the acute setting, really, because those you can screen with cardiac MRI, really it's the patients who come in very sick, who are too sick to get a cardiac MRI, that then you can take them to the lab. This is a rapidly progressive and unexplained cardiomyopathy. You're starting to see arrhythmias, high-grade blocks, or ventricular arrhythmias, or you can't stabilize them with your GDMT. You're starting to think about, do you need inopressors or mechanical support? These are people that you enrich your population for giant cell myocarditis, and these are the people that I would recommend taking to the cath lab for biopsy. All right, let's move to genetic testing now. I think this is another really hot topic in this field about when you see patients with new-onset heart failure. What should we be doing about genetic testing? Well, here's a third case. This is a woman who I've known for some time. She, in 2010, as a 25-year-old, was diagnosed with what we thought was a peripartum cardiomyopathy. And she had progressive heart failure, and ultimately 6 years later had to have a durable LVAD implanted. Back then we were putting in HVADs. She did okay, but then 2 years later, she had to go for a heart transplant. She just wasn't satisfied with the quality of life. And on her explant, she had evidence of diffuse lymphocytic myocarditis, basically. So we thought peripartum cardiomyopathy, maybe myocarditis. She was transplanted. It was 2018. I would emphasize back then, we weren't doing genetic testing. And all was going fine until 5 years later. And in December 2023, her teenage son was playing tennis and started having chest pain. And so they took the son, to the emergency room, and this was his echo. It was massively hypertrophied. It was a depressed ejection fraction. And to make a long story short, they sent genetic testing on him, and he turned out to have a stop codon in LAMP2, which is diagnostic of Danon disease. And so all of a sudden we realized she didn't have peripartum cardiomyopathy. She didn't have myocarditis. She had Danon disease, and we just didn't know it because we hadn't done the genetic testing back in 2018. Now, back then we were not doing it routinely, and so I understand why we didn't do it, but it does have very important questions when you think about all those patients that I have now who I never tested in the past, and I'm just seeing back in clinic routinely, and I'm not doing genetic testing on them, or at least I hadn't been. Well, he had high burden malignant ventricular ectopy. He had marginal hemodynamics. He was listed and he was transplanted about 3 months ago. And that's gone well. And so it's a good ending. We're very fortunate, but you have to pause and think that very easy to imagine that there could have been a very different and even a catastrophic outcome on that tennis court. I mean, he could have collapsed and died suddenly. And we would not have known that he was at risk because I and our team had not done the genetic testing on our patient. And so I think this case for me really illustrates and highlights the value of why we really need to start doing genetic testing more commonly. So what's known about Danon disease? Well, it's an X-linked disease caused by loss of function mutations in LAMP2. In our case, they had to stop codon. LAMP2 plays a critical role in how the lysosome and the autophagosome fuse. Basically, if you knock this out, there's a defect in autophagy. And so without LAMP2, you start to accumulate all the cellular waste, if you will, and that leads to hypertrophy and cardiac toxicity. If you look at it, men or males, they develop severe LVH and arrhythmias in adolescence. It's 100% penetrance because they only have one copy. There's some other minor organ involvement. The son there's not much for us to think that he had something going on. But the women, they present 10 years later, and typically they'll present with a dilated rather than a hypertrophic cardiomyopathy. So I like this cartoon. This is a analysis, a registry that had 150 or so. 90 of them were men, and you can see that they present here like at age 10, and they all, by the age 20, they're all really sick. Whereas the women are presenting later with a hypertrophic phenotype, and then about 10 years later is when they get really sick. And that's exactly how it played out with our patient. She presented at age 25 and then got really sick and had to have the LVAD. He presented in his teenage years. And so exactly what this diagram highlights. So for me, this is what really is compelling, is that the implications are not only for the patient you're seeing for new-onset heart failure, but for their family. And again, I would think back to all the patients that we never tested back then when we weren't doing routinely, and we're just kind of following them along in our clinic. Maybe they've reverse remodeled and you just see them. And it's a great visit because everyone's doing great. But you don't realize that, you have to kind of pause and realize, well, there may be family members out there that are at risk of this condition, and we're not affording them the opportunity to be identified because we didn't test our index patient. Well, how likely are you to find a pathogenic or likely pathogenic variant when you do this? Well, one question is, well, how common is a familial cardiomyopathy if you take patients with all comers of dilated cardiomyopathy? I think the best data come from the DCM precision study. I don't know if you're involved in this with Ray Hirschberger. It's an NIH trial. And what they basically did is they took patients who had diagnosed dilated cardiomyopathy, and then they took their probands first degree relatives. There were about 1,400 of them, and they excluded anyone with a known cardiomyopathy. So these were 1,400 first-degree relatives, none of whom had been clinically recognized to have a cardiomyopathy. And then they did echoes and saw whether, in fact, they did have a cardiomyopathy or not. And it turned out that 12% of these relatives who were not known to have any cardiomyopathy had either left ventricular enlargement more than the 95th percentile or an EF less than 50. And another 2% of them had both criteria. So they met the definition of a dilated cardiomyopathy. So what we found really is that 1 in 7 of apparently unaffected first-degree relatives have either a dilated cardiomyopathy, significant left ventricular enlargement, or an ejection fraction less than 50%. Undoubtedly, they're affected as well. So that's not that rare. 1 in 7 of our patients are also affected. Well, if you then delve a little deeper and say, well, what about if you actually do the genetic testing? How common are you going to find a variant? This is a meta-analysis of 46 studies, and it turned out that it was about 20% of the time you can find a genetic cause of the cardiomyopathy if you screen them with coloring panels. And so the yield is, it's not 1%, it's about 1 in 5 that you'll get a positive hit. And now what's emerging in the literature now are strategies to increase, even if you're not happy with 20% and you want to increase it, there are now some multivariable risk scores that are emerging in the literature. This is from Spain. And what they did is they came up with a 5-point risk score: myopathy, family history, low voltage, no hypertension, no left bundle. And you can see here in the derivation, this is in the blue, and in the validation in the red, you can see that as the subjects or the participants have more of these factors, they're more likely to have a positive genetic testing. So if you're not happy with 1 in 5, you can screen using this to enrich the likelihood of having a positive genetic test. I would say I think there's 2 common, what I'll call misperceptions about this, as you're thinking about who to do this in. The first, I think, misperception is that, oh, well, the patient's presenting at age 60, late onset, I don't have to worry about it because it's a late onset cardiomyopathy. Well, these are data, this is published from JAMA Cardiology. They had 184 participants who had dilated cardiomyopathy at greater than age 60. And what you can see is that when they tested them, almost 1 in 3 of them had a positive genetic test. So just because your patient's presenting at a later stage of life, that doesn't mean that it's not a genetic cardiomyopathy. So I think that's one misperception. I certainly, until I saw had these data, I thought, oh, it's a late onset, it's probably not. But I think I was wrong in retrospect. In fact, even if they're presenting late, you can find things like Titin variants or even lamin A variants. And don't overlook cardiomyopathy genes even when there's another overt etiology. I'm not going to go into these data, just showing you the publications, but peripartum, alcohol-induced cardiomyopathy, if you have cancer therapy-induced cardiomyopathy, and if you have even acute myocarditis, if you screen those individuals, you're going to find that a reasonable percent of them have a genetic cardiomyopathy gene, likely that caused, or in a kind of a 2-hit hypothesis, led to them developing their cardiomyopathy. So what do the guidelines say about this? Well, in non-ischemics, we said, of course, family history for everyone. And then in select individuals with a non-ischemic, refer for genetic counseling and testing. Our European colleagues, though, a year later, they went beyond that. They give it a class 1 recommendation. They say genetic testing is recommended in patients, and then they list all these criteria. It's literally, it's hard to imagine someone who wouldn't fit one of these criteria. So basically, they're saying in everyone, you should do genetic testing in new ischemic. And the rationale, and I'm aligned with the Europeans again on this, is that cascade screening could save the lives of the relatives by leading to GDMT. And I'm not going to go into this, but there are certain high-risk variants that can lead to ICD implant, even if the ejection fraction is greater than 35%. And so that if you find a variant, an RBM, and the EF is 40, normally I wouldn't have put an ICD in, but if I find one of these high-risk variants, I do recommend putting in an ICD. So I think there's definitely therapeutic implications of doing this. So this is my opinion. This is not, I'm not talking for the US guidelines, but in my opinion, genetic testing will become routine in the evaluation of non-ischemic cardiomyopathy. And I think it's going to be, even if there's another apparent trigger, something like a peripartum, toxin-related cardiomyopathy, or myocarditis. All right, so let's get to the last of the 5 questions. And that is, how long to wait? You have a patient, they come in with new-onset cardiomyopathy, new-onset reduced ejection fraction, how long do you wait before you implant an ICD? Well, as you think about this, you're really balancing two parts of the equation. You're weighing the risks and benefits. The risk, of course, is that while I'm waiting, my patient will drop and they'll have sudden death, and that the ICD might have prevented it. Certainly, we don't want that to happen. On the other hand, if you wait and you treat with GDMT, many of those patients are going to have an improvement in their EF such that the ICD is no longer indicated. Now, our EP colleagues may not like that, but think about how many patients you might spare of having an ICD implantation with the attendant risks. And so you have to weigh these, in my opinion, you have to weigh these two factors. Well, I'm taking us back to 2012, and Dr. Rao was one of our co-authors on this study. This was a observational study from Parkland Hospital. We had about 200 individuals who had paired echocardiograms on clinical grounds. And of those, almost half of them improved. These are all who had qualitatively severely depressed. We want to make sure it was less than 35%. And of those, almost half improved such that their EF was then judged as either being mildly depressed or normal, meaning that they would no longer have an indication for an ICD. We did two sensitivity analysis because this was just retrospective. This wasn't prospective. There were a lot of people who didn't get a second echo. Maybe they died, or maybe they just never came back and got the echo. So the first sensitivity analysis is anyone who died, we counted as not improving their EF. There were 13 deaths over 18 months. And so still, it was still about 40% of people improved their ejection fraction. If we said, okay, anyone who we just never had another echo for, we'll just assume they didn't get better, what would be the percent? And it was about 1 in 4 still improved the ejection fraction. So somewhere even, worst case scenario in terms of the bias, somewhere between 1 in 4 and 1 in 2 patients back in the era of 2012, this is pre-ARNI, pre-SGLT2, were improving their ejection fraction if you waited such that they no longer needed an ICD. Well, more recent data now, this is from a registry, HF-OP. This is a registry where they took people who had new-onset cardiomyopathy and were referred to have a wearable cardiac defibrillator. And then they followed them for a year, basically. And all the individuals got guideline-directed medical therapy. This is now pre-SGLT2 data. And if you go, for example, out to 180 days, so 6 months, what you're seeing here is the median ejection fraction is going up. And if you just say, well, what percent of patients had an EF greater than 35%? At 6 months, 68% of individuals, 68% of individuals had an EF that was greater than 35%. And if you went out to a year, that number rose to almost 80%. I mean, the power of modern day GDMT. And so as you're weighing, should you wait or not, I think you have to really consider, weigh this pretty heavily in my mind. And so this is what Dr. Dimser recommended. This is the algorithm that we put forward. You have a patient with new-onset heart failure, reduced ejection fraction. You initiate your GDMT. At 3 months, evaluate the ejection fraction, but consider what we called risk modifiers. The risk modifiers include, do they carry a high-risk pathogenic variant? If they have a lamin A, I'm going to treat them differently than if they don't, for example. Do they have an ischemic or non-ischemic cardiomyopathy? Ischemic being more likely to risk of sudden death. Do they have extensive late gadolinium? Do they have persistently elevated natriuretic peptide levels? Did they have syncope or palpitations? And are they intolerant to GDMT and specifically beta blockers? These are all risk modifiers, in our opinion, about how much longer you're going to wait than what typically has been done, which is the 3 months. And then we did emphasize this is really one of those cases where you need to do shared decision making. I will tell you, having done this a lot, almost everyone, almost all my patients want to wait longer if I think it's reasonable. So let's say at 3 months, now you're greater than 35%, you're done. You don't have to worry about an ICD, assuming they don't have a high-risk variant. But let's say at 3 months, they're still less than 35%. What should you do? What we're recommending is if they have significant risk modifiers, the lamin A, or they're not doing well clinically, and I'm just never going to get them onto full dose beta blockers, or they look decompensated, or maybe they had a syncopal event, those people I refer for primary prevention. But let's say they don't have any of those risk modifiers, which many of these patients don't. Then at shared decision making, I'll reevaluate the ejection fraction at 6 months. And then I see what happens at 6 months. At 6 months, if it's more than 35%, again, no lamin A mutation, no high-risk variant, no ICD. But let's say I start to see some improvement. The EF now is gone up maybe 5 points, but still I'm less than 35%. I'm seeing improvement. I'm going to wait longer and see what happens at 12 months if the patient's willing to do that. If the EF has not changed at all, I mean, I see nothing. The EF is still 20% at 6 months. For me, that's enough. If I don't think we're going to get there, I feel comfortable at that point referring for primary prevention ICD. And then at 12 months, then that's usually when I'll call it off. I have gone even a little longer than that in some patients. Usually I won't go more than 18 months because if you look at GDMT, how long can you wait? Really, you get most of the bang by 12 months and almost everything at 18 months, you're done. You're not going to get any more improvement than that. So this is the algorithm that we're proposing. I think there's a lot of patients out there who are getting ICD who won't need an ICD if you follow an approach like this. Some people may say, I describe this as being very aggressive with GDMT. Some people may say I'm being conservative with ICDs. I don't think so. I think I'm being aggressive with GDMT, and I think I'm sparing a lot of my patients ICDs that end up that they never get shocked and then does them no benefit. So I personally think this is the right way to go. And so these are the conclusions of these 5 questions. Should an ischemic evaluation be performed in all new onset heart failure? Of course you should. You're going to do screening, H&P, EKG, you're going to do an echo and all. And then the pretest probability of the coronary disease influences the choice of the next diagnostic test. I think this CAC equals 0 is a reasonable rule-out strategy. And for others, then I decide CMR, coronary CTA, or invasive angiography. Should cardiac MRI be obtained in all? I think so, if it's feasible. It identifies conditions requiring the etiology-specific therapies, as well as the prognostic information. In contrast, though, endomyocardial biopsy, the risk outweighs its benefits in most patients. So the ones that I would recommend doing it, rapidly progressive heart failure or arrhythmic presentations, really thinking about that giant cell myocarditis, and also to diagnose the amyloids, the sarcoids, those other infiltrative diseases when the non-invasive approach is not successful. The genetic testing, I think we should be offering genetic testing to all patients, ideally with a genetic counselor. We're happy to discuss that in the Q&A. I think that is a limitation about how do you actually implement genetic testing. I'll be interested to hear what Dr. Rao says about that. And then the rationale is the diagnostic, prognostic, and therapeutic implications for the patient and, importantly, their relatives. Think back to my patient's son on that tennis court. How long to wait? You share decision-making, delay for 12 months, and the duration of that waiting period is influenced by these risk modifiers that we talked about, the clinical events, ischemic, non-ischemic, the genetic variants, how much gadolinium they have, and then the overall clinical stability is measured by their natriuretic peptide levels. So again, really appreciate the invitation and look forward to participating in the discussion. Thank you.
Thank you, Dr. Drazner, for this wonderful talk. Very insightful, given that new-onset heart failure is one of the most common reasons people in the hospital. Questions? See, Dr. Hunley already has a question.
Mark, thank you for such a clear, coherent presentation. And, you know, as you know, go way back, every time, whether it was the board review course or whatever, every presentation is exactly that way. Question. So looks like lots of algorithms with different types of data could be useful in formulating whatever therapeutic decision is made, ICD, transplant, et cetera. How is artificial intelligence being used to amalgamate some of all this information today so that when a patient comes in and you're seeing them, all that data is collected and actually you could maybe forecast what would be going on at 12 months?
Yeah, I think that's a great question. I have not seen AI in terms of, ICD implant or really ICD implant. There are data looking at what I am excited about is AI interpretation of EKGs. And I have seen data, you could even predict certainly ejection fraction off of a simple screenshot of an EKG AI, and they can predict whether the patient has cardiomyopathy or not. How that works, I don't know. They also can predict your gender off of that. And I've seen cases where we've had people who are working this come and give grand rounds like this, and they'll show the EKG and you look at it, it looks normal. And yet the algorithm can say this person has a reduced ejection fraction. They also can do EKG age, and they can, what looks like a normal, they can tell you someone is aged 20 years younger or older based on that. So I think that is very exciting. I haven't actually seen though, and I don't know if in terms of predicting recovery of ejection fraction, I haven't seen any data on that, but undoubtedly that's, and I think that's a great question. And I didn't include it because I haven't really seen it, but in terms of the screening algorithm, maybe we won't need to do maybe we'll just do the EKG AI and know whether the person has ischemic cardiomyopathy or not, and that whole question may go away. I haven't seen anyone yet do that, but I won't be surprised about them. So great question.
Thanks for the talk, Dr. Drazner. For this group that you're treating with aggressive medical therapy, and it seems like there's a growing population of heart failure with improved ejection fraction, especially in the younger group of patients that we treat. And they invariably are asking, well, can I stop these medications? What's your practice now?
Yeah. So as we see GDMT is good, 70–80% of people recover their ejection fraction. So what do you do then? And of course, patients always want to come off medications. I think we have pretty compelling evidence about what to do now. And the bottom line is you don't want to stop GDMT. And there was a TREAD-HF, which was published in Lancet now a few years ago, took a relatively small number of individuals and tried to withdraw GDMT, and it didn't go well. Either the left ventricle dilated, the ejection fraction fell, natriuretic peptides rose. It was a small trial, it was like 50 people, but then some of those individuals, when they put them back on GDMT, you could not re-recover them. And I would say even before that TREAD-HF, there were observational data. One initial study was from the landmark Swedish group who showed us that beta blockers worked, and then it was replicated in Japan, where they took people, and this was largely beta blocker treated individuals, and they withdrew the beta blockers. And this is observational data, but the event rates were very high. I was even surprised that the Japanese group was willing to reproduce it. And honestly, when TREAD-HF came out, I had some concerns, and Dr. Thibodeau, my colleague, and I wrote we wrote to Lancet, and they published it, and they wrote back. I had some questions about the ethics of that, because even the data, the observational data was so compelling to me before that I wondered whether it was really the right thing to do to subject it. And then if you looked at those participants, some of them cannot be re-recovered. Now, they pointed out that the patients were informed and they knew what they were going into, and they all really wanted to come off their medicine. So nevertheless, I think the answer is very clear. Don't stop the GDMT. And that is a problem, because a lot of times you could easily imagine patient comes in, we stabilize them, we follow them, then they go, let's say, to a primary care office, they see the person, they feel great, the ejection fraction is normal, and they may say, not knowing these data, they may say, oh, you don't need all this. And then, invariably a year later, they're back in with, depressed ejection fraction, and sometimes you can't stabilize them again. So in general, I think, now a more subtle question, and this is, I think, a really hot topic, is quadruple therapy GDMT. So the push in the field now is that with new-onset heart failure is in that index hospitalization, get people on quadruple GDMT. So what you're really saying then is if you're not going to withdraw GDMT, you're basically committing everyone with new-onset heart failure to quadruple therapy for lifelong. I don't know if that's the right answer or not. I certainly know I would never stop a beta blocker. What would happen if you took an MRA away from someone who had fully recovered their ventricular function and you kept them on beta blockers? I don't know. In TREAD-HF, they would kind of withdrew everything. And so we didn't really get an answer. But I think that's a really important question that we don't know, like who needs quadruple therapy lifelong and who can get away with just staying on, for example, beta blockers and a RAS blocker. We don't know that answers to that, but there's going to be a lot of people on quadruple therapy as we start everyone on the index hospitalization.
In your experience, which of the medications would you withdraw if a patient wants to have low pill burden of the 4 GDM?
Yeah, as I said, we don't know. I try not to withdraw any of the 4. If they're on, what I do withdraw is if a patient historically is on digoxin, I will withdraw that cautiously, because there are data that if you withdraw digoxin, randomized data showing that you can exacerbate heart failure. So I down titrate it, and then I watch them it's not a trivial thing. And then I de-escalate in diuretics. But I am concerned about, until we know who's safe and not safe with quadruple therapy. I would point out there are data now that there's pretty good data looking at an SGLT2 inhibitor withdrawal syndrome. And so these data that from the SGLT2 randomized data, at the end of the trial, people got taken off their study drug. And so it's done in a blinded fashion. And it turned out that the patients who had been on SGLT2 had higher event rates than the people who had the placebo withdrawn. So there is an SGLT2 inhibitor withdrawal syndrome. So it's not trivial to stop that either. So I don't know, who it's safe and what's safe to, the one that the data I haven't seen yet is MRA, but that's not clear that, that there isn't a withdrawal syndrome to that. That's how I do it. Now, it gets a little tricky. The one case, if you have, let's say someone comes in, people always ask about, okay, a patient came in with a fulminant case of influenza A myocarditis, and they fully recovered. Do they need their lifelong GDMT? I don't think we have an answer to that, but I would say that I would genetically test that person because I know that a decent number of them have a genetic cardiomyopathy gene. And if they have a genetic cardiomyopathy gene, I would be much less likely to withdraw, even if there's an overt precipitant, than if they didn't have that. So even in those cases, I would do the genetic testing before I withdrew the therapy. And the last thing I'll say is I think the terminology is important. In the guidelines, we don't talk about recovery, we now call it remission. And I think that's a good way to think about it. Our patients are in remission, and that doesn't mean that if you take away the therapy, it can come back. And it's not like they're cured, they're in remission. And I think that's I think the guidelines, I think Beacom was the one who spearheaded that, if I remember correctly. I really like that terminology, and that's the way when I speak with my patients, because the question is, well, do I still have heart failure? Which is a complicated question. And then I kind of pivot and talk about, you're kind of in remission and you're on therapy. As long as we keep this therapy going, you should be fine. And then don't let anyone stop it without talking to me. That's usually the conversation I have.
Guys, I really appreciated the talk and your focus on some of the powerful diagnostic tools that we have now. But spending some time in the CMR space, one of the common critiques is that it's an expensive test. And so I'm wondering, can you comment on how the professional societies or payers might be thinking through the cost effectiveness of more broadly applying these tools to the heart failure population?
Yeah, it's a great question. I don't really have any insights in terms of, on a national societal level, talking about reimbursements and things like that. I think the next question is going to be when the Heart Failure Guideline Committee reconvenes. How is that going to be handled? And then I think, once you get in the US guidelines, then I think you have more influence, I would say. But I don't have any personal insights into that. It's an important question because we could say, oh, we want to do all these things. But if the payers are not going to support it, it's going to be hard to implement. In fact, that was part of the genesis of the myocarditis expert consensus decision pathway. We wanted to, longitudinal follow-up, and so that payers hopefully will support that. That was part of the impetus of that.
My name is Swetha. I'm one of the fellows here. Thank you so much for that wonderful lecture. I was actually wondering about ICD placement in patients with a reduced ejection fraction, less than 35%. A lot of times we get patients in-house with new diagnoses who cannot tolerate GDMT for whatever reason outside of Jardiance. In those patients, have you seen in your experience that there's still evidence to wait 3 months to see if there's an improvement in LVEF on just Jardiance?
Yeah, so the question is, you have a patient who's pretty sick and not tolerating GDMT, and so they're unlikely to recover. What do you do? The challenge there is that the indication is to wait for a trial GDMT, and there was this is a little historical, but there was a Department of Justice investigation into what they would call inappropriate ICDs, implantations. And so they went and they looked for people who didn't meet the criteria, and that was a Department of Justice investigation. So now, people are understandably skittish about going against those indications. So then the question comes up, well, should you put a wearable cardiac defibrillator on those people? The challenge there is that the randomized data haven't really shown benefit, and the event rates, if you even look at the HF opt registry, the event rates were so low, it was like 0.5% in 90 days of all comers, that it's hard to show that there's going to be actual benefit of doing that. So it's a difficult question, and you could talk to, if there's someone who's having salvos of, VT and, but if you just have new-onset cardiomyopathy and they're on medical therapy, but you get them out of the hospital, but they're just not tolerating GDMT, my experience has been hard to get ICDs before some time window passes. Again, though, I would point out those people, I'd be worried there could be something else going on and think about, those people have some other cause. So that population, like it's not, most people new-onset heart failure, you can stabilize them, get them on GD and get out. But there's a small percent of people who present and they're just sick. Some of them present fulminantly and they end up like that index hospitalization. They end up with balloon pumps or temporary support and end up with transplant. But there's another fraction of people who are so sick at that index presentation that literally I have to discharge them on inotropes. And, those are the people that are different. And I think you have to think about that group. They're different than the vast majority of people who tune up pretty quickly. You get them on GDMT and you can up-titrate in the outpatient setting. The ones who are sicker at that index admission, I'd be worried about there's something else going on. And maybe it's a high-risk genetic cardiomyopathy, maybe it's myocarditis, but I would investigate that group to see if I can figure out what's going on before I just send them out.
My name is Arun. I'm one of the first-year cardiology fellows. The first question is, if a patient has time progresses to heart failure with reduced ejection fraction, how do you approach treating such patients? And the second question is with regards to the flow chart that you showed, are there any clinical decision support tools that can be embedded within the EMR system that would help us make the appropriate decision in terms of diagnosis and sign?
Yeah, great question. So the first question is, if a patient starts out, their index presentation is HFpEF, but then their trajectory is such that they go on to develop reduced ejection fraction, what do I do? I think once the ejection fraction falls and they're in the HFrEF category, I treat them like that. And the reason treat them in the HFrEF bucket, the reason I do that is because they presented a HFpEF, but you may have just as easily encountered them a year or two later, and then they would have been entered into the randomized trial. So I think it's reasonable once they fall into that category that I would treat them as HFrEF, even though their index presentation was HFpEF. Now, I would think about why, certain etiologies come to mind, and I would start looking at that. The second question is about how to actually implement like a flow chart like this, and can you embed decision support tools into the EHR to help us? And undoubtedly, it can be done. Whether that improves outcomes or not is another question. But I think, there's this whole thing about decision alert fatigue, which I know I experience. I just click through things. So you have to think about that. But there are some data, I think reasonable data now emerging that EHR techniques are beneficial, for example, in getting us to use GDMT better. If you think about in the outpatient setting, there's some reasonable data now suggesting that EHR alerts do prompt that. So I think that undoubtedly one could do this. Again, this is just a flow chart that our group proposed. It's not a guideline, and I'm not sure there's universal agreement. Well, I know there's not universal agreement that we have the right flow chart, but certainly one could use the EHR to screen, and certainly make sure that people are doing things that we know, like should they get on, you make sure they're on, at least tried on GDMT early on.
And Dr. Drazner, I'll draw your attention to the chat. Dr. Contos, you already answered that question. When waiting for the final decision for an ICD, would you recommend placing a live vest while waiting?
Yeah, again, I think that the randomized data just aren't strong. It would be, but there are some people who I still do, and those are people who I'm worried about for some reason. And whether that's I'm seeing ectopy, certainly if I'm sending them out on inotropes, that I would then consider a life vest. But overall, most people, there's just not good data yet for that.
I think Dr. Huser is also in agreement that his suggestion. I cannot agree more with the fact that EP had too aggressive with implanting ICDs. I would suggest to add screening for PVCs in these patients too. Many patients have high burden PVC that likely result in PVC-induced cardiomyopathy that is not considered in the diagnosis.
Great point. I think I would agree with you that, finding people have high burdens of ectopy and you ablate PVCs, you can restore ventricular function. So I think that's a great point. Thank you.
And Dr. Abate has about 3 questions. Number 1, for genetic testing, do you retest periodically in high suspicion, i.e. every 5 to 10 years to see if new mutations or new data? Second question, ICD decision, do you ever integrate Holter or event monitor? Third question, systemic inflammation, any role of measuring biomarkers to stratify risk?
Yeah, so the genetic testing is a really important question about how do you repeat it. The panels are getting better. 5 to 10 years is kind of a new therapeutic approach. So I don't have 5 to 10 years of experience, but the important point I think is that I refer all my patients to genetic counselors And then they file, for example, because a lot of times you get variants of unknown significance. And we as practitioners don't have an ability to really follow that, but my genetic counselor does. And so they can then bring that patient back if that variant of unknown significance has been reclassified. So that's where I think it's very important to involve your genetic counselors. Holters or event monitors, that's something that I've routinely been doing. It's certainly during the index hospitalization, though, everyone's on telemetry, and I kind of get a feel for the burden of ectopy, and then again, asking them about palpitations or syncope, but I don't routinely screen with Holters in the outpatient setting. Systemic inflammation, any role of measuring biomarkers. I think you're meaning, like, for example, does someone have myocarditis? I think if someone presents with new-onset heart failure in a clinical picture that looks like myocarditis, certainly troponin and then some inflammatory marker like a CRP would be very reasonable to do.
I think last question in the chart. What do you think of, that's from Dr. Hahn. What do you think of the new adeno-associated virus vector-mediated gene therapy, like for the Danon disease?
Yeah, so in San Diego now, they're delivering therapy for individuals who have Danon disease with the adeno-associated virus, and show that you could express it in the myocardium. And I think that's another reason, I didn't discuss it, but I do think that's another reason genetic testing, we should be doing this, because invariably we're going to get to the point where we're going to think back on the days where we're just using GDMT for everyone as kind of crude, and we're going to be able to directly attack the problem. We could fix the LAMP mutation. We can fix the myosin heavy chain. Probably in the young people in the room's career, it may even come to reality in your career. And so if we have this, but to do that, you kind of need to know what everyone's mutation is. So I think that's another reason that genetic testing, because we need to acquire this database so that we know which variants people have. But yeah, I think ultimately that's where the field's going to move. And I would predict, I don't know, maybe it's decades from now, but I think they're going to look back on what we were doing as pretty crude. Like, why were you giving the same medicine to everyone when this person had this mutation and this person had mutation B? I'm optimistic we're going to get there, but it's going to take some time.
All right. Thank you, everyone, for coming. Thank you again, Dr. Drazner, for this fantastic talk.